Well, good morning. My name is Robert Victorino. I am an AP in the EMT and Paramedic programs here at Portland Community College. I've been in EMS for about 12 years. The past 5 have been full-time teaching here while working part-time on the ambulance with Skamania County Emergency Medical Services up in Washington. Another quick introduction before I begin. All those folks in the white uniform shirts back there are PCC's 2014 paramedic cohort. Throughout their education process, we have them present a few similar presentations to their colleagues, and I have invited them here today to evaluate my presentation using the same rubric that we use to grade their presentations. So my classroom should be an interesting place this afternoon. Let's go ahead and get started. Today I'm going to talk to you about what a heart attack really is and how we as paramedics identify and treat it in the ambulance when you call 911. And if I accidentally put anybody's eyeball out with this thing, I sincerely apologize. The most common cause of a heart attack is a blocked artery. Oops, now it's working. Is a blocked artery. The heart does not receive oxygen from the blood that pumps through it. It has a network of small arteries on its surface that supply the heart muscle with the oxygen that it needs. The problem with those arteries is they're small and they clog easy, and there's not a lot of redundancy. So if one of them becomes clogged, doesn't have a backup to supply the heart with the needed oxygen. There are some risk factors that we can't control, such as age and family history, but there are some that we can control. High blood pressure, diet, obesity, stress, lack of physical activity, and smoking. You can see actually that some of these are interrelated. If we get a handle on our diet, that will automatically impact our weight and our blood pressure. We can handle stress by a little bit of physical activity will eliminate stress. That will also impact our blood pressure. Smoking, well, just quit. It's the single worst thing you can do for your health. If you're smoking, do what you can to smoke, to quit smoking, sorry. All right? However, we hear the term chest pain when we think of a heart attack, but symptoms can vary. If your heart is suffering damage, blood supply to your brain and to your lungs can be affected, and that can present with dizziness, fatigue, shortness of breath. Your body's responses to injury can result or can present with nausea and sweatiness as well. Also, individuals' response to pain or individual perception of pain can vary. Some folks may sense a pain in the jaw or a pain in the left arm or perhaps a pain in the back. Some folks are very adamant about it not being a pain but a pressure. I've had patients who every time I asked them about their pain, they were very specific to correct me that it wasn't pain and it was pressure. There are some factors that control how this is presented. As we age, how we perceive pain changes. Men and women perceive pain differently. Men often present with the chest pain or chest tightness, with a pain in their left arm and a pain in their jaw, whereas women will present with just some dizziness and maybe some fatigue and a pain between their shoulder blades often. So pain changes, or the symptoms can change. A little bit of biology review to help us understand what's going on. Your heart, like your skeletal muscle, responds to electrical impulses. But the difference is, while I have to think about an impulse to move a skeletal muscle, one of the heart's special properties, called automaticity, is that it creates its own electrical impulse. It does that on its own without you having to think about it. However, creating that impulse 108,000 times a day takes a lot of energy. And our cardiac cells create that energy. Oops, I'm going the wrong way. Back up. Our cardiac cells create that energy using oxygen, and they require a constant flow of oxygen. The skeletal muscles in your body can go for long periods of time without a fresh supply of oxygen, 10 or 15 minutes. But your heart muscle needs an uninterrupted supply of oxygen to do its job. When we're young and our arteries are fresh, blood flows through them unimpeded. As you can see here, we got nice, good blood flow. Over time, as we age, cholesterol deposits build up in the wall of the vein with perhaps some questionable dietary decisions or lack of exercise. These deposits get larger and larger, and as they get larger, they begin to limit the flow of blood past them. We often hear people complaining of they notice that they become winded sooner, or after activity, it takes them longer to recover from exertion, commonly called angina. If you have chest pain and you sit down and it goes away, this may very well be what's going on. And the reduction of exertion lets the blood get through and the chest pain goes away. Over time, however, that little deposit will rupture. And when it does, the blood does what it's supposed to do. It creates a clot. Another response to that rupture may be that the vein has a spasm and squeezes down even tighter. Either way, what ends up happening is blood flow past that clot is stopped completely. At that point, what happens is any heart muscle that is fed by that artery, fed oxygen by that artery, begins to suffocate. And there's a very small amount of time that we have to get blood moving past that clot before that muscle suffocates and dies completely. Once it dies completely, even returning flow will leave the heart less functionable than it was before. So, first of all, I need you to stop doing whatever you were doing. Reduce all physical activity. Activity requires energy, and energy requires oxygen. Oftentimes, people talk about fatigue or dizziness, so sit down. Sit down before you fall down. You don't want to compound the heart attack with an injury from falling down. I know it's kind of silly to say relax if you think you're having a heart attack. I want you to just relax. But remember, anxiety requires oxygen as well. So do what you can to try to relax yourself a little bit. Call us right away. Don't worry about a false alarm. If we get there and you've changed your mind, we'll just move on to the next call. It's no big deal. Don't worry about wasting our time. Time is muscle, so get us started immediately. Don't try to drive yourself to the hospital or have somebody else drive you to the hospital. Hospital resources change minute from minute, and the closest hospital isn't always the right hospital. If the closest hospital has had an influx of patients, their labs and their imaging resources may be being used. So we may need to pick the right hospital for you. Also, if you decide to drive yourself and things get worse, you could die. You could die on the way to the hospital, and that would be unfortunate when an ambulance is just a short phone call away. When you call 911, you're going to get a hold of a dispatcher, and I see we have some of PCC's dispatch students in the back of the hall as well. They're going to ask you some questions. They're going to ask you what's going on. They're going to ask you your address, and then they're going to get us on our way. Once we arrive, we're going to ask you a bunch of more questions. We're going to check your vital signs. We're going to get an IV started. So those of you that are afraid of needles, that's just too bad, as our psychology friends say. And then we're probably going to put you on the heart monitor as well. This is our heart monitor. I'd be willing to bet that most of you have probably seen one of these in movies or on TV. This is actually one of the models that we use to train our paramedic and nursing students here at PCC, so they learn on this exact heart monitor, Notice the little sticky pads here and here. Those are the pads that they're going to stick to your chest so that they can take a look at the electrical activity of your heart. They'll probably start with 3 or 4, and then each one they add will give them a view of another aspect of your heart. The heart is a 3-dimensional organ. We want to be able to see all of its surfaces. So we're going to stick a bunch of stickers on your chest. Hopefully this volume isn't too loud. So this is what an EKG looks like. I'd be willing to bet that my pulse rate is probably a little faster than that one right now, but that's what it looks like. And I'm going to stop it here so we can take a closer look. All right, so let's look at this one right here. This is an entire cardiac complex. This piece from here to here is the electrical discharge. That's the charge that makes the heart contract, that moves the blood and gives you a pulse, the pulse that you can feel in your wrist or your neck or even in your throat, like I do right now. But that's where you get that. This section from here to here is the heart recharging that electrical impulse. And that's where we see the earliest signs of that loss of oxygen. So when we've put you on our heart monitor, what we're looking for is a change in this little spot right here. We're looking to see if this is higher than this part here. Easy enough, right? It should be pretty simple to see. Now, all of my paramedic students are laughing because it's not quite that easy. Remember, I told you that we look at several aspects of the heart, several areas of the heart at the same time. We typically look at 12 regions of the heart at the same time. So this is a full EKG showing 12 regions of the heart at the same time. And there is a heart attack on this 12 lead. I hope my paramedic students can see it. For those of you who haven't gone through any of my lectures yet, I'll point it out for you. Here is the heart attack right here. So the skill and the art of interpretation comes in discerning these little minute specks of elevation in all of this information. That's what the paramedic is looking for. This section that we call the ST segment, if it is elevated, it's possibly a heart attack. Now, just because it's elevated doesn't necessarily mean it's a heart attack. Your signs and symptoms will help us diagnose that. Also, just because there is no elevation doesn't mean that there's not necessarily a heart attack present. A doctor using the imaging and the lab resources of a hospital is required to definitively diagnose if there's a heart attack or not. So let's talk about a little bit about our interventions. Paramedic pre-hospital cardiac interventions focus on getting blood past the clot. There is a short list of medications that we may or may not use to try to get that blood moving again. And we're going to talk about the what and the why. First of all, oxygen, plain old oxygen. If you're complaining of shortness of breath with your heart problem, we're going to check your oxygen level using a little sensor on your finger. And if it reads low, we're going to give you supplemental oxygen using that mask that everyone has seen on TV or that little hose that everyone has seen on TV to try to get your oxygen level back up to where it's supposed to be. If your oxygen level's good, we won't administer supplemental oxygen. We'll just leave you on what we call room air. Oops. Why does everybody instinctively point this at the screen when the receiver's over there? All right. Next, we're going to give you some aspirin, plain old aspirin. If you haven't had any surgeries in the past few days, we're going to give you probably plain old baby aspirin, the kind that you chew and swallow, that terribly orange flavored aspirin. We give that for a couple of reasons. First of all, if you chew it, it has a chance to absorb into the lining of your mouth and get into your bloodstream faster. Second, if you are experiencing some nausea, I don't want to give you a big drink of water to swallow the aspirin with because that's just going to end up on the floor of the ambulance in a few minutes. The reason we give you aspirin is one of its side effects is it prevents clotting, further clotting. It doesn't break up the clot that's already present. It prevents that clot from getting bigger. The doctor in the hospital with a cath lab is required to get rid of the existing clot, but we can stop it from getting larger with aspirin. Next, we're going to give you some nitroglycerin, the same old nitroglycerin that we all saw in the old West movies where they're blowing up the trestle bridge, that same exact stuff. This nitroglycerin is diluted significantly, so you don't have to worry about it blowing your head off or anything crazy. It's usually given in a spray under the tongue or a small pill under the tongue. Patients usually complain about a minor headache with it, but it's more important to get the blood flowing around your heart, and we'll deal with the minor headache a little while later. What nitroglycerin does for the heart is it relaxes the arteries around your heart. So if one of them is clogged by a small clot and it's had a spasm, we're hoping that this nitroglycerin will get the muscle in the artery to relax, and maybe a little bit of blood can squeeze past that heart, enough to keep that heart muscle alive while we get you to the hospital. If you do get a little bit of a headache, we can fix that with the next drug, morphine. And pain jumped up there quick by itself. We're going to give you some pain medication. We give pain medication for a couple of reasons. First of all, pain causes anxiety, and it also causes the fight or flight instinct in your body, that mechanism that says I'm in trouble. And that mechanism uses energy, and energy requires oxygen. And all of our treatments are geared toward getting the oxygen demand in your body reduced so that what oxygen is getting to that area of the heart it's not using as much of it. So we're going to give you some pain medication as well. Oftentimes there will be a synthetic analgesic substitute on ambulances for folks. I've had patients who have not been comfortable with taking narcotics, and we often carry a synthetic option called fentanyl that we can give instead. Oftentimes, a heart attack or narcotic pain medication will produce nausea. For that, we give a drug called Zofran, and that takes away the nausea. So if you're concerned that I take morphine and it makes me nauseous, so when I'm having a heart attack, I don't want to take the morphine because it's going to make me nauseous. Well, I can fix that too. I'm going to give you this drug Zofran, and it's going to take away your nausea. So that's the medications that we use. And at the beginning, I told you that depending on your history, some may or may not be given. I mentioned aspirin not being given if you've had a history of surgeries recently. Another option, paramedics may forego nitroglycerin if the patient has used any of the erectile dysfunction medications in the past 48 hours. Nitroglycerin may not be given either. So while this is a list that we have, they're options, and your specific presentation and history will dictate which drugs are able to be used. Our treatments are geared toward getting rid of the symptoms. But just because the symptoms are gone doesn't mean the heart attack is ended. You still need to get to a hospital. We still need to take you to a hospital where the blood flow around your heart can be imaged, where lab values can be assessed to look for cardiac damage. You still may need to have that clot opened physically by a small wire inserted in the artery in your leg. They thread it up into your heart and get rid of that clot. The doctor may have you wear a tiny, tiny little heart monitor so that your cardiac electricity can be tracked throughout the hospital or even at home. Remember, you know yourself better than anybody else. If something doesn't feel right, just call 911. That's what we're here for. This is the job that we've chosen. You're not a bother. You're our job. Thank you for your time. You're welcome. Oh, thank you.
That's for you. Lovely parting gift.
Swag.
Swag. Yeah, go
Swag.
ahead.
Before I unlock all this stuff, are there any questions? Yes, sir.
So that scene in Pulp Fiction where
Let me guess.
Travolta jams the needle into Uma Thurman's heart to get it started again after a drug overdose.
Um,
Give me the true or false, Robert. What's wrong with that scene, or why is it accurate?
Do you remember the movie?
I do remember the movie. Yeah. It's not accurate anymore. That is an extreme intervention that we don't use anymore. There are other options that are a little more reliable to deliver a large dose of epinephrine to a heart if somebody dies. One of the cool things that we teach our paramedics to do is this thing called intraosseous access, where we have a drill with a large needle, and we'll drill into the bone. Everybody remembers that where you make your blood is in your long bones. Well, we can drill into a bone and deliver medication directly into the marrow, and you can't miss. So that not so much anymore. Not since the 70s, maybe. Any other questions? No? All right. Thank you for your time.
Yeah,
I
got a
appreciate it.
question.
Oh, wait. Did we?
One question.
Yeah, just have one question.
Yeah.
When you were talking about putting someone up to the machine and reading the muscular activity, how long does a heart attack last? I always thought of it as something like, I had a heart attack, by the time the paramedics got there, it's over. But it sounds like you're saying it's still going, there's still evidence of it.
There is. You have, depending on the severity of the blockage, you can have a small heart attack that lasts for quite a while, or you can have a large heart attack that lasts, I guess, forever. I guess is what the large heart attack would last forever, because you would be dead and it would be bad. There are, the network of arteries kind of dictates whether it's a large heart attack or a short heart attack, and how much tissue dies has an impact on that as well. I talked about the automaticity of the heart and how it creates its own electrical signal. There are specific groups of cells who do that, and if those cells are part of the cells that die during the heart attack, the heart can stop rather quickly. So we have from the time of occlusion, or where it's blocked, we call it occlusion, to the time of a lethal cardiac rhythm can be seconds to hours. That's why it's so important to call 911 immediately. If you're just not feeling right, if you're sweaty for no reason, I love the term a feeling of impending doom. Just something that isn't quite right, but there's no reasonable explanation for it. Call 911. Everyone is always, I don't want to call if it's not really needed. Don't worry about it being needed. We'll come and check you out and see if it is or not. And that's what we're here for. We like to drive with lights and sirens. Don't take away that opportunity for us. We want to drive really fast and make a lot of noise. So that gives us that opportunity to do that. And that's why like I said, it's so important to call early, because the longer you sit and debate with yourself of whether or not this is really a heart attack, the more muscle is dying. And the problem is, even if you survive the event without calling, that dead muscle never works again. So the output, the overall output that your heart can do is decreased. And your lifestyle after that will also be decreased. We have a very active outdoor population in this area. You would lose bicycling, you would lose mountain climbing and skiing on the mountain and surfing at the coast, because your heart wouldn't be able to keep up with those activities. So it's important that you get us there so that we can work on what we call reperfusion, getting the blood moving past the clot as early as possible to prevent long-term cardiac muscle damage.
So going back to Rob's question, are you saying that at one time that was how they might?
That wouldn't be for a heart attack. That would be for cardiac arrest. So yes, that is true. You watch some of the old ER shows, the old hospital shows. You'd see, the doctor come rushing in the room with this big overhand swing, with this harpoon about that long and right into the chest. But we don't do that anymore. It's much more humane. Yes.
So if you're with somebody that you think is having a heart attack, obviously sitting down with them, getting them calm, calling 911 would be the top 3 things to do. Is
Yes.
there anything beyond that person should do?
Well, while our interventions are geared toward reperfusion on scene, ultimately the patient needs to be in the hospital for management under a doctor. So if you have the resources, extra family at home, maybe getting that person's medications together, maybe have somebody go throw in a house coat and some slippers into a little overnight bag. Don't have them move around. If you're upstairs, don't have them walk downstairs, because that's exertion, and exertion requires energy, and energy requires oxygen. So have them sit there. We'll carry them downstairs. That's what we've got a giant fire department and EMS service for, carrying people downstairs. Don't give them a glass of water, because the nausea that is often associated with a heart attack, that water's just going to end up on your feet. Any other questions? Yes.
I had a question.
Well, you got a microphone.
She gave me the mic, and that's a dangerous thing to do. I might start break out a song here. Anyway, no, but I have 2 things. My cousin, he's only 19. He had a heart attack and a stroke. He's a diabetic, and so I'm wondering. You kind of answered the question already, but I always wonder about the aftermath, the post situations with heart attack victims. So if they have like a lot of like you said, cholesterol built up.
Yeah.
So is it just enough exercise, changing their diet? I mean, I always think that they had a heart attack, can't they just have another one? If they got one heart attack, seems like they could have them all the time if one was caused by the...
Heart attacks are caused, like I said, the most common cause of a heart attack is a clogged artery. However, when you have a young person like that, typically the cause of the heart attack is a congenital heart issue. So he may be at risk for further heart issues as he ages. My bet would be that it probably wasn't a cholesterol blockage. It was some other congenital thing. I talked about the patient's history, your history having an effect on all of this stuff, and diabetes in particular is a very destructive disease. People kind of don't give it the respect it deserves because it's gotten to the point where it's so common in our society. But diabetes itself is hard on every body system, particularly the circulatory system. One of the things that it does is that extra sugar floating around inside the circulatory system makes our veins and arteries harder than they should be. So when a clot and a spasm happens like that, the artery is no longer nice and soft and supple, and it can't flex. It's a hard tube. And that's one of the side effects of diabetes. So it sounds like he's got some hurdles that he's going to have to work on.
Yeah, it runs in their family. They have, all the uncles have already passed.
Yeah, and that's what another aspect of the family history is your ancestors, your immediate ancestors. My father had 2 bypasses in his 50s, so I figure got about 5 years to go before I am saving up vacation time because I'm going to spend some time in the hospital.
You don't want to say that.
Hopefully, by the time I'm 50, they'll have like I can get a baboon heart or something really cool.
You'll be fine. You'll be fine.
I'm saving up for a robot heart.
Okay.
Any other questions? Yes.
So I'm happy to know there are people who are skilled and can help me if I have a heart attack, but I'm much more interested in never having one.
Absolutely.
So when I looked at your little picture, you showed that tiny little mound in there, and you showed some blood going by, but it existed there as your cholesterol before the clot. Can you actually reduce the clot's size, or is it one of those things where you've started building a mountain and the only thing you can do now is prevent it from getting bigger?
No, you can absolutely reduce the size of the cholesterol deposit through dietary changes, high fiber diets, or one of the things that has come up in the last few years is what they call a Mediterranean diet. Those diets and exercise. You reduce overall body fat index. You're going to reduce that fat deposits that are inside your arteries as well.
And wine, red wine, right?
A lot of red wine.
Yeah.
I'll make a note of that.
Yeah.
Not beer. You got chocolate. So overall exercise and dietary changes can make a big difference. The tricky thing about those deposits is they're not on the inside of the vein where we could go and scrub them out with a little tiny bottle scrubber. They're inside the wall. So the only way that you can get rid of them is through some serious surgical interventions if you're that far advanced, which they don't just do when you show up and you can I have my cholesterol taken out? It doesn't work that way. You got to work for it, like everything else in life.
That's fine, as long as it can be.
There are options. There's hope. There is hope. Anything else? All right. Thank you very much. Thank you for your time.